Jennifer Fink, and I am the co-founder of Atlanta's A Cure in Our Lifetime. It's Breast Cancer Awareness Month, and we are so glad that you signed on to learn about genetic testing for cancer prevention and treatment. With us tonight, we have Dr. Jane Meisel from Winship Cancer Institute of Emory University and Karen Grinzaid from JScreen. So welcome to both of you. Before we get started, let me just give a little plug for A Cure in Our Lifetime. If you can take your phones and go to Instagram right now, please follow us at Instagram. It's where we kind of can keep you updated with everything that's going on. So it's at A Cure in Our Lifetime. Sign up for Instagram, and also sign up for our emails by visiting our site, atlantacure.org, and we will put both of these links in the chat tonight. We'll also be recording tonight so that we will distribute it and you can share it with others. And there'll be an opportunity for people to ask questions. So without further ado, let me turn it over to Dr. Meisel and to Karen. Thank you.
Thank you so much, Jennifer. We're thrilled to be here tonight and really excited to give this presentation. Just a little bit of background about myself and also about my relationships with Cure in Our Lifetime and JScreen. So I'm a medical oncologist at Winship Cancer Institute, and I've been here since 2015. I specialize in treating breast and ovarian cancer, and I run clinical trials for patients with those diseases as well. And I also teach medical students and young doctors, both at the bedside and in the classroom. I've known Jennifer and Jody since 2018 or 2019 or so. And ever since I met them, I've just been so impressed with the dedication, knowledge, passion, and generosity of the leaders of A Cure in Our Lifetime. I've been to their annual breakfast many times now over the past 5 years or so, and the quality of the speakers and the amount of support that this group is able to garner for breast cancer continually blows me away. And our group at Emory has been fortunate enough to benefit directly from this support, with funding for a number of really meaningful research projects and trials supported by A Cure in Our Lifetime's philanthropy. So it's a pleasure and a privilege to be involved with them and to be here tonight. I became involved with JScreen right around the same time, actually, at the same time as I met Jennifer and Jody, when Karen and her colleagues approached me with an idea about cancer genetic testing. So JScreen, which Karen will tell you more about, had historically been centered more around reproductive carrier screening, so screening for expectant parents to see what the likelihood might be that their child could develop a genetic disease like Tay-Sachs or something like that. They got me involved as a breast and a gynecologic medical oncologist, so we could talk about whether genetic testing for cancer-related genes like BRCA1, BRCA2, and now many others we're learning about would be something the general public would be interested in accessing. So we conducted a pilot project looking at logistics and uptake of testing, as well as the patient experience. And the pilot went so well that cancer screening for a large panel of cancer-causing genes actually is now part of JScreen's general offering. So with that, we'll move on to the meat of our presentation, and Karen and I look forward to taking questions. So please feel free to put your questions into the chat as you think of them, and then we'll answer them, hopefully all at the end. And then Karen, I think you will hopefully be able to share the presentation and maybe advance the slides for me in the beginning. Perfect. We can go on to the next slide. Yeah. So this is a little bit of an outline of what we're going to be talking about tonight. So we'll talk about answering a few questions, really. So one, what is the risk? We'll talk about sporadic cancers versus hereditary cancers. We'll talk about quantifying the risk of cancer in BRCA1 and BRCA2 mutation carriers specifically, and also talk about some of the other genes that can be implicated in breast and ovarian cancer. We'll answer the question, should I get tested? This can be a difficult decision, and we'll talk about some of the things that go into making those decisions. Then there's the question, if I test positive, what next? We'll talk some about the outlines for cancer risk reduction for mutation carriers. And then if I already have cancer or I get diagnosed with cancer, could knowing more about genetics change my treatment plan? So we'll talk about options for cancer treatment that are unique to mutation carriers and can actually improve prognosis. And then we'll also talk about testing for other family members. And go on to the next slide. Maybe some technical challenges here.
They're not. Oh, there we go.
There we go. All right. So hereditary breast and ovarian cancer. So most women, about 70% of women with a breast and ovarian cancer, have sporadic cancers, meaning they're random and they're not related to anything inherited. Then the other 30%, some of those patients will actually have an identifiable gene mutation known to increase cancer risk. That's known as a hereditary cancer. And then a larger number, 10 to 20%, will have what we think of as a familial breast or ovarian cancer. So that's a situation where you have a strong family history of breast cancer or ovarian cancer, but multiple genes and lifestyle factors are probably involved, and there may not even be one gene that we can identify today that's causing that. So the majority of women, at least that we know of now, with hereditary breast or ovarian cancers, carry a deleterious mutation in either BRCA1 or BRCA2. These are the most common breast and ovarian cancer causing mutations that we know about and can test for. And then there are other genes associated with increased risk of breast and ovarian cancer as well. So PALB2 is one of these genes, CDH1, ATM, CHEK2, and BARD1. There are a number of others as well. And the more we learn about these genes and the larger numbers of women we follow with these genes, the better we're able to come up with really more quantifiable risks. And also what should people do about this? Because I think that's one of the biggest questions that comes up when you get a genetic testing result is, what does this mean for me? And what should I do differently? We can move on to the next slide. So risks in different populations. So this is, I think, also important because people wonder, how likely am I to actually have one of these mutations to begin with? So in the general population, as we know it today, 1 in 500 women have a genetic change that increases their breast cancer risk. But Ashkenazi Jewish women and men have a higher risk of breast cancer due to a higher rate of BRCA mutations. So if you look at the population as it stands, of those with Ashkenazi Jewish background, about 1 in 40 will actually carry a mutation. Now, it's not a huge number. It's still something like 2.5%, but it's a lot more than 1 in 500. And then interestingly, Black women diagnosed at a young age with breast cancer are twice as likely to have a BRCA mutation than white women with breast cancer diagnosed at the same age. So for example, a Black woman with breast cancer diagnosed at 35 versus the same woman with white background diagnosed at 35, the Black woman might be twice as likely to carry a BRCA mutation. And I think this is increasingly important to know too, because some people think, oh, I don't need a genetic testing done, I'm not Jewish. But it actually can hit people from multiple different backgrounds. We're learning more and more about that as more people get tested for these genes. We can go on to the next slide. So quantifying cancer risk, this is hard to do for some genes, but we actually know a fair amount about this for BRCA1 and BRCA2. And I think seeing these risks of cancer developing side by side, especially compared to the population with no mutation, is really important. So if you have a BRCA1 mutation, depending on the studies you look at, the risk of developing breast cancer by the age of 70 can be as high as 57 to 65%. Some studies even say higher. If you have a BRCA2 mutation, it's a little lower, but still really hovering around 50% or even 60%, depending on what you look at. Whereas if you don't have a genetic mutation, the risk of developing breast cancer by the age of 70 is something like 1 in 9 to 1 in 10, like about maybe 10 to 12%. So really a big difference in terms of the cancer risk that you carry if you have a genetic mutation like this. And same with ovarian cancer, which can be sometimes a lot harder to treat, and is something I'm happy to talk more about during the Q&A if people have questions about this. But for patients with BRCA1 mutations, if you've got that mutation and live to the age of 70, the likelihood of being diagnosed with ovarian cancer by that age is actually quite high if you don't do something to mitigate your risk earlier on. So along lines of 40 to 60%. If you have a BRCA2 mutation, that risk is a lot smaller, but still higher than the general population, where the risk of ovarian cancer is something like 2%. If you have a BRCA2 mutation, it's still somewhere between 10 and 20%, depending on the studies you look at and on your family history. We can go on to the next slide. Perfect. So this question of should I get tested is one that I think a lot of people ask themselves. And this question, the answer to that question is complicated. There are a lot of factors that go into this question of should I get tested? And as you can see from the woman in this photo, this is a question that can really engender a lot of anxiety as people are thinking it through. We can go on to the next slide. So some of the considerations that people take into account, first, of course, are family history and personal history. So testing may feel more critical for those who have a strong family history of cancer or those who even have a family member that they know has a genetic mutation. I think in any situation where you feel like what we call the pre-test probability, the likelihood that you might have a positive test or mutation, the higher that is, the more likely it is that people are sort of considering, I think, getting testing done because they know they might be able to act on it. And then there's the question of how will I handle the information? It's not always the right time. I often have people ask me, how old should my daughter be before she gets this test done? And, I think that people need to be at an age and a stage in life where they can handle the information. I think connectedness with healthcare teams helps. I actually have some people who come to see me without any cancer, even though I'm an oncologist, really just to be counseled about, hey, I found that I have this mutation. What should I do next? And who do I need to see? So I think sometimes when people feel connected with their healthcare team, even before considering testing, they feel better about the idea of getting tested because they know that they'll have access to resources that they need should they have a positive test. And then there's that question about, will the information be actionable? Will it help me make decisions about my healthcare going forward? And will it impact my cancer screening plan? And I think the answer is almost always yes. Knowledge is power, and I tell people that all the time. If you know what you're dealing with, then you can, use the best information available to you to figure out how to act on it in a way that makes sense for you. But I think all these things are important to take into account as people are considering if they should have genetic testing done, and then of course, when in their lifetime they should do it. I'm going to the next slide. So, that question about actionability, I think, is a really important one. And recommendations for female BRCA mutation carriers, you can see here that it really, really is important because it changes what you do pretty significantly compared to someone who doesn't have a mutation and might just be getting mammograms every year or even every other year, depending on which guidelines you look at. So for patients who carry a BRCA mutation and are female, for breast cancer prevention, it's recommended to have clinical breast exams every 6 to 12 months, beginning at age 25, to start doing annual breast MRIs at age 25, and then to start alternating mammograms and breast MRIs from 30 up until age 75. And this kind of intense imaging protocol often engenders, even if you don't develop a cancer, you can have false positives or changes that bring you back for additional imaging. And all of this can be quite stressful, especially if you know you have this mutation. And so many women will consider at some point risk-reducing mastectomy, meaning almost preventative mastectomies to reduce the risk of cancer, and then, of course, avoid the anxiety and the time and everything that comes with all of this screening. And I think there's a time and a place to consider this too, and it is such a personal decision. I've seen patients who know that they have a BRCA mutation as early as their mid-20s, but feel like they don't want to have surgery yet because they'd like the chance to have children and breastfeed before they do this. I've had others who've said, oh my gosh, I found out I have this mutation, I need to do this right away. And then still others who find out that they have a mutation at the age of 60 and they maybe have other medical problems or aren't great surgical candidates, and they choose to just continue the screening. So I think there is no one-size-fits-all routine here, but following some or all of these recommendations to the extent that you can is probably very important for cancer risk reduction. And even if you get cancer, it's better to have done these screening protocols because you can often catch a cancer earlier if you're screening for it than if you wait to find it when you feel something. And then ovarian cancer prevention is a bit more complicated because we don't have great screening tests for ovarian cancer the way we do for breast cancer. And so for patients who are at risk for ovarian cancer with a BRCA1 mutation or BRCA2 mutation, we recommend removal of the fallopian tubes and ovaries actually by age 40 to 50. And which age you do that at can, of course, depend on a lot of different things. Generally because BRCA1 mutation carriers are likely to develop ovarian cancer slightly earlier in life and have a higher likelihood of it, like I showed on the last slide. We typically recommend that BRCA1 mutation carriers have their tubes and ovaries removed closer to 40, whereas BRCA2 mutation carriers can often wait till age 50, especially if they don't have a family history. But again, I think important to have healthcare providers you trust so you can talk this through and figure out what program of screening or preventative surgery really makes sense for you if you're found to have one of these mutations. We can go on to the next slide.
Sometimes they don't advance. Just a second.
No worries. Take your time.
Well, there we go.
There we go. So this slide is just looking at recommendations for male BRCA mutation carriers. And I think even the fact that a male can be a BRCA mutation carrier is sometimes a surprise to some people. People assume because breast and ovarian cancers are predominantly female diseases that this might be a gene that only gets passed through women. But that's actually not so. So men can pass this gene down to their daughters. And men also, it's important for them to know about it for themselves because their cancer risk changes. So male breast cancer is actually much more common in patients who carry BRCA mutations. And so for males who have this mutation, we recommend clinical breast exams every 12 months, starting at age 35. So not just feeling around yourself, but actually going to a doctor and having that doctor examine you. And then prostate cancer is higher risk for male BRCA mutation carriers. And so we recommend PSA screening starting at the age of 40 for men who carry this mutation. We can go on to the next slide. And for all BRCA mutation carriers, we recommend annual skin checks by dermatology due to a slightly increased risk for melanoma. And then pancreatic cancer is another one that's important. So pancreatic cancer, like ovarian cancer, doesn't have great screening tests, but the screening that we do have is a little bit more invasive. And so screening for pancreatic cancer is recommended for patients who have BRCA mutations, and particularly those who have a history of pancreatic cancer in a close relative. So for those patients, they actually are recommended to see a gastroenterologist and consider alternating every year doing an endoscopic ultrasound versus an MRI of the abdomen to screen for pancreatic cancer. So important things to think about because these are newer recommendations. And I think with BRCA mutations, people don't always think pancreatic cancer, but it is an important associated disease as well. And go on to the next slide. And then there's some additional things to consider also. And I think these are important to think about as you think about testing, and certainly if you test positive, as you think about what this means for your lifestyle going forward. So reproductive concerns can be an issue for a number of reasons. I was already talking about with preventative mastectomies, the timing of considering that can often be impacted by the desire to bear children and potentially the desire to breastfeed those children. If someone wants to do that, they may want to have their children before they have their mastectomies, which in many cases is totally fine to do. And there's also that more delicate question of how do I feel about the possibility of passing this mutation on to my child? And am I prepared to think about doing something about that? So some people will consider actually doing in vitro fertilization with pre-implantation genetic testing if they have the opportunity and option to do that, where essentially embryos are created with eggs and sperm and then tested to see if those embryos carry the mutation passed down from the affected parent or not. And if the embryo carries the mutation, then they may not be chosen to implant. But if the embryo doesn't carry the mutation, then they may implant that embryo into the uterus and then carry that baby to term. So these are things to think about as you talk to yourself and talk to your doctor about what you want to do if you find yourself in this situation. And I think with the oophorectomy question, there are lots of questions about this, but I think the main one is this question of, assuming you're done with childbearing, planning for slightly premature menopause. So for some women, of course, if you've got a strong family history of ovarian cancer at a young age, that risk is going to trump the risk of slightly premature menopause. But for some women with that, you want to consider, your bone health, your heart health, and how that might be impacted by removing your ovaries and thus all sources of estrogen production before you reach an age where, you would normally be experiencing that. And I think it's something important to talk to your doctor about because not everyone is always thinking about this. But for example, there may be some situations like a patient who has a non-estrogen driven breast cancer and then has bilateral mastectomies for that cancer, who then could actually have safely implemented hormone replacement after oophorectomy, and then kind of mitigate some of those risks of slightly premature menopause. So I think all these angles are important to talk to and to speak with doctors and experts about so that you make sure you develop the plan that works for you the best. And then mental health concerns. I think this is something that cannot be overstated, and I think sometimes does not get as much attention as the things that are sort of easier to quantify. But mental health concerns can be a big deal. So the fear of cancer is a huge thing. I think if you have a mutation that might cause a risk of cancer, especially a cancer at a young age in life, you can be very afraid that that might happen to you. And if you've had cancer, the fear of cancer recurrence can be very, very real. And in some situations can be, something you really have to wrap your mind around how to get over and how to, compartmentalize it so that you can move on with the rest of your daily life. And then telling family members can be challenging too, because if you have a mutation that has been passed down from someone else or that you could pass along to someone else, you're telling family members not only something important about your own health, but something that can implicate their health as well. And then finally, body image and sexual health, I think are a big piece of this also. If you're having breast surgery or going into premature menopause, there are a lot of issues that can impact how you feel about your body and how you feel about your sexuality that can impact your mental health as well. So all these are important to consider. We can move on to the next slide. So, and then patients who have breast cancer, I think this is also important to think about. For a lot of patients in my clinic, the impetus to undergo genetic testing is actually because they're diagnosed with breast cancer at a young age, or because they're diagnosed with breast cancer and they have a strong family history. And it's still important. It's not, some people say, oh, if you already have breast cancer, like the cat's out of the bag, you weren't able to prevent it. But actually learning about your genetic profile and what you've inherited when you've been diagnosed with cancer can help a lot because it can impact your treatment as well as, of course, prevention. We can move on to the next slide just to talk about that a little bit. So for a patient who's diagnosed with a BRCA mutation after being diagnosed with breast cancer, it can change management in a couple of ways. If a patient didn't have a mutation, in many situations, they would have a lumpectomy, which is just removal of the tumor itself and some tissue surrounding it, along with a lymph node under the arm, just to make sure the cancer is not spread. But if a patient has a BRCA mutation, instead of having a lumpectomy, they might choose to go ahead and have the mastectomy, both to remove the cancer that they've been diagnosed with, but also to consider prevention of future cancers. So it might impact surgical decision-making. And then now, as of the past few years, we actually have systemic treatment options that are specific to BRCA mutation carriers. This is a wonderful thing. These PARP inhibitors, which are oral drugs, target the same cellular repair mechanisms that are made vulnerable by the BRCA mutation. So it's essentially a targeted treatment for BRCA mutation carriers. And we have several of these drugs approved in breast cancer now. Olaparib and talazoparib are two PARP inhibitors that have been proven to be superior to chemotherapy in previously treated BRCA-positive metastatic breast cancer. And these really have changed the way we treat this disease and the way we think about it, because it both improves length of life and patients' quality of life significantly, because the side effects are often a lot less significant than the side effects of chemo. And then for patients who have BRCA mutations who do not have metastatic disease, there are some patients who we know now from clinical trials actually benefit from taking 1 year of olaparib, a PARP inhibitor, by mouth, and that can lead to a higher likelihood of cure. So again, very important to know about your mutation status, because it might impact your treatment and your chance of curing your breast cancer if you are diagnosed with it. We can go on to the next slide. So, and then finally, thinking about BRCA in patients with new ovarian cancers. So with breast cancer, we've expanded the indications for genetic testing more and more over the last decade, but all patients with ovarian cancer actually recommended to undergo genetic testing. And classically, this is not done in all patients, but it really should be, because up to 15 to 20% of ovarian cancer patients will actually carry a BRCA mutation, even if they don't have a family history. This is actually a very common sort of index cancer diagnosis for BRCA families. And so for ovarian cancer patients who are found to have BRCA mutations, these same drugs, these PARP inhibitors, are now part of the standard of care of curative therapy. So it used to be, even when I was in fellowship training, that we would often test these patients much later on because we didn't necessarily have options to change their management at this time of diagnosis. But now trials have shown that using a PARP inhibitor after chemotherapy, almost as maintenance, can be a big part of curing these BRCA mutation carriers of their ovarian cancer if the PARP inhibitor is used right away. So it becomes more and more important to be testing these patients at diagnosis. Yeah, so I'm going to pass the buck to Karen now, just to talk a little bit about cancer mutations and your family and what that means for you. And then I'll stay on so we can, of course, open it up to questions at the end.
Thanks, Dr. Meisel. So again, I'm Karen Grinzaid. I'm a genetic counselor, and I'm executive director of the JScreen program at Emory. We've been talking about this, but I just want to reiterate that cancer mutations are hereditary. And what that means is they're passed from parent to child. And I know that seems obvious, but when people think about genetic diseases like, say, Tay-Sachs or sickle cell disease, you're thinking about a contribution from both of your parents. But in fact, most of these cancer gene mutations are inherited in what we call an autosomal dominant way. And what that means is once a parent or an individual has one copy of a mutation, say in the BRCA1 or BRCA2 gene, it just takes that one copy of the mutation to cause the problem. So each of their children has a 50% chance of inheriting that mutation and then themselves having an increased risk for cancer. It's not a contribution from two parents. It's a contribution from one of your parents. And that can be your mom or your dad. And a lot of people don't think of it in that way. They think, oh, breast cancer, it's always going to come from mom. But if we're looking back at family history, you also want to be thinking about your father's mother, her sisters, you know, anyone on either side of the family with breast or ovarian cancer, which might indicate an increased risk. And the same goes for your children. We're thinking about not only daughters, but also your sons having an increased risk, because as Dr. Meisel said, even with BRCA, we're talking about not only breast and ovarian cancer risk, but also pancreatic and melanoma. In addition to that, prostate cancer risk in men as well. So if a person was interested in doing cancer genetic testing, and look, it can be a person who has cancer, it can be a person who has a family history and they're worried about it. It can be just an individual who's worried about it. Maybe they have friends who are impacted, or they have Jewish background, African American ancestry. They're just concerned about their risk for hereditary cancer. There are multiple ways that you can get testing done. Number one, you can go to your doctor and ask if they can help coordinate testing for you. And many doctors can help you do that. One thing that I would be careful about, or just make sure of, is that the doctor knows which genetic test to offer. So for example, even just breast cancer alone, as Dr. Meisel was saying, there are multiple genes now that are involved in breast cancer risk. So you wouldn't want to be going to the doctor ordering just BRCA testing, because there are other genes involved in breast cancer risk. And the same goes for other types of cancer. So just need to make sure that doctor's in the know about what testing to order. Another thing that you could do is go see a genetic counselor. That genetic counselor would sit down with you and take a cancer family history, and based on that history, decide what genetic testing would be appropriate to offer. And in Atlanta, there's Winship, and there are other cancer genetic centers that have counselors who are very educated and proficient in this area. And across the country as well. Or you can take it upon yourself and find cancer genetic testing, and there are different places where you can do that. And I would caution here not to go to a direct-to-consumer company to get that type of testing done. So for example, if you went to 23andMe and got your ancestry and other, associated genetic testing done, they would do a BRCA test on you, but they would not be looking at the whole BRCA gene. They'd be looking at just minimal changes in the gene. And that's not reliable or very accurate or sensitive testing. You want to get a medical grade testing done for this kind of concern. One way that you can do that is through our program, which is JScreen, and I'll explain to you how a person would get tested through us. And what we've tried to do through JScreen is, and again, we're a program based out of School of Medicine at Emory. So we're a very medically involved genetic screening program, but we were trying to make 10 years ago, genetic screening accessible and affordable. And the way that we did that was we let people go online and order the testing from home, and made sure that we had genetic counselors and medical geneticists involved through that process to make sure appropriate testing was being ordered, and that genetic counseling happened on the back end so that you would have a good understanding of your results. Everything being done from home, the testing and the genetic counseling, which is done via telehealth. So I'm not going to spend a lot of time on it, but a couple of years ago at a national level, we started offering cancer genetic testing through our program. So if you go onto our website, which is jscreen.org, you'll see there's an option for what we call our cancer gen test. And that's in fact a panel of 73 cancer susceptibility genes. So these genes are associated not only with increased risk for breast and ovarian cancer, but also a host of other common cancers. For example, colorectal, prostate, bladder, melanoma, multiple other types of cancer. So you can get a good overview of your hereditary cancer risk through this test. We offer this testing for anyone who's 21 years of age or older. And even if somebody registers and they're under 25, we'll talk to them about actionability of results, based on your age. The test is appropriate for not only women, but again, also men and anyone from any ethnic background, because I know if we go way back and think about the JScreen program, we think about screening the Jewish community for reproductive concerns and even cancer concerns. But in fact, the panels that we offer are appropriate for anyone of any background, and we have people of all backgrounds coming through our program. You can also access the testing from all 50 states. And the kits are mailed to you, so you can be in any state in the US to get the testing done. So also, if anyone's interested, I just wanted to mention this on the webinar today, that to register for a kit, you go to jscreen.org, make sure you order the Cancer Gen kit. If you live in the Metro Atlanta area, you can, when you're checking out on the payment page, you can enter coupon code SCREENATL, and that'll take $100 off the cost of testing, which would leave $99 as the cost. Courtesy of a Jewish Federation of Greater Atlanta. We're very thankful for that grant through Federation. And if you're outside of the Atlanta area, you can use coupon code JScreen50, which would take $50 off the cost of testing. So multiple ways of getting genetic screening done. In conclusion, we know that the risk of cancer is significantly increased in people who've inherited mutations in BRCA1 or 2 or other cancer susceptibility genes. As Dr. Meisel said, really knowledge is power. If you learn about your carrier status, it can help you develop a cancer risk reduction plan. And if you do develop cancer, it can help optimize your treatment. And we're getting better and better at that over the years. Also, once a cancer mutation is identified, other family members can benefit from testing as well, because they will also know about their cancer risk and take action toward improving their health long term. So I wanted to thank A Cure in Our Lifetime for inviting us, for Dr. Meisel for sharing your wisdom, and we wanted to open it up for questions.
Karen, I don't think the chat function is enabled. So can we go ahead and enable that as well? And I see there's also a question there under the Q&A.
Let's see if
Karen, do you see the question? It's from Hillary about CHEK2 mutations. Do you want to speak to that, or do you want me to?
No, you can. You go ahead, Dr. Meisel.
Yeah, no, and Karen, feel free to jump in too. I think CHEK2 is one of these genes where 10 years ago we really didn't know that much about it, and we're starting to learn more and more, just because with more people getting testing and being able to follow more patients, we're able to understand more about some of these genes that are a little bit less common than BRCA1 and BRCA2, but still are out there. So CHEK2 mutations are probably found in 2 to 3% of women diagnosed with breast cancer. Some of those studies differ in terms of the number, so it's not uncommon as far as genetic mutations that cause breast cancer go. But some of the studies suggest that the CHEK2 abnormality can approximately double the lifetime risk of breast cancer. So if the lifetime risk of breast cancer for a non-mutation carrier might be 12%, say, it could be 24, 25% for one with a CHEK2 mutation. It can also increase the risk of colorectal and prostate cancer. So I think it's important for men as well as women to know if they are a CHEK2 mutation carrier. But this is one of those mutations that I do sometimes see in my patients who've been diagnosed with breast cancer who then go on to get panel testing. And this might be one of those things where if you have a breast cancer and you find that you have a CHEK2 mutation, it might push you towards a double mastectomy as opposed to having less aggressive surgery, just because you want to reduce the risk of a second cancer later on. And I think we are one of the beautiful things about big data is that we are learning rapidly more and more about genes like CHEK2. And are able to encourage people to get screened so that we can, find these things that are actionable. And Karen, I don't know if you want to add to that more specifically.
No, that's great.
Let's see, another great question. What if you had a gene test and a gene comes back as inconclusive, but is identified?
Do you want me to take that question?
Yeah, go for it. And I can add after you're done.
Okay, so when you do genetic testing like this, you can get one of 3 different kinds of results. One, you could get a negative result, meaning they didn't find any changes in the genes that they studied in the lab. Number 2, you can get a positive result, meaning that they found a mutation in a gene, and we know what that mutation means and what kind of risks are associated with it. But they can also report back a variant of uncertain significance, meaning that this change in the gene is not known to be associated with an increased risk for cancer, but on the other hand, it's a change and they don't want to report it back as negative. In the long run, the vast majority of these VUSs end up being classified as non-disease causing because further evidence is accumulated and it's not something that we would be worried about. And we generally counsel people that we will let them know whether the mutation has been classified as potentially pathogenic or disease causing, but not to worry about it. Sometimes in a family, we'll see multiple people with these variants, and then we would go back to the laboratory and say, can you relook at this? But for the most part, we want to make sure people don't make medical decisions based on this type of variant. Did you want to add to that, Dr. Meisel?
Yeah, and I would just say I think it is one of those things where we do have to counsel people that almost every single one that I've seen has come back as being, if it's inconclusive, then later becoming something that is not anything to worry about. But the system actually also does work very, very well in terms of if genes are identified or mutations are identified that become significant later on, we do find out about it. So I actually had one patient of mine where that did happen, where a VUS in a BRCA gene was found to later be a deleterious mutation. She was notified, I was notified, and we actually were able to put that information into action for her in terms of her treatment plan. So I think the system does work very well to sort of update people over time with these classifications. And we've got another question, and Karen, this may be another good one for you actually. If you were tested more than 5 to 10 years ago, do you recommend getting retested?
Yes, I'm going to answer yes. And really, so much has been learned over the last, even couple of years in terms of changes in these cancer susceptibility genes. And if a person was tested years ago, I'll tell you that the best thing to do would be to contact whoever coordinated your testing and ask if there's new testing that's available that would be relevant to you. And for example, even, let's say somebody got tested 10 years ago, many of the genes associated with increased risk for breast cancer were not identified. We didn't know that these changes in these genes increase risk. So it's definitely worth at least checking on availability of update of testing panels.
Yeah,
Dr.
no,
Meisel, did you want to add to that?
I've got nothing to add. I would agree completely. Let's see. And I think we had a couple of questions that we'd come up with and that folks had sent even before this evening. And maybe we can dive into some of those as others are thinking of additional questions. One of these we kind of touched on a little bit. If I'm a mutation carrier, what should I do about getting my children tested? How old should they be before getting testing done? Karen, I don't know if you want to jump into that and I can add on.
Yeah, I said before that, well, through the JScreen program, anyhow, we don't test minors for anything that we test for. And we say 21 and up for cancer genetic testing. And even 25 and up makes a lot of sense, because if you got a positive result back, you would want to make sure there's something that you can do around prevention, early detection, and Dr. Meisel can add to this, but in a woman who's under 25 years old, there's really not a lot that you would do in terms of monitoring or screening to look for early signs of cancer. Now, that said, if there's a hereditary cancer in the family, and people have gotten cancer at younger ages, it may be appropriate to get that testing done earlier.
Yeah, I think I agree with you completely. I think that would be sort of the only situation in which I would recommend doing it before 25, just because I think it's a lot of information to be having and holding when you're still in that sort of stage of life where you're very much finding yourself, and where for the most part, unless you have a strong family history of cancers under, 25 or 30, there's not going to be anything you're going to do about that risk before the age of 25. So I often say, to my patients who ask, I would probably wait until your child is closer to at least 21, if not 25, just because also testing is getting better and better, and if someone's got a child in their early teens, the quality of testing and the amount of knowledge we're going to be able to gain from that testing may even be greater by the time the kid gets older. So I think waiting till that age makes a lot of sense, just because I think, the older you are, the more ready you are to handle the information. It also is sort of more empowering to be able to do something about it once you have the information. If you're 19 and you just have to sit with that information for 6 years, you may kind of wish that you had compartmentalized it and put it off for a little bit.
And Karen and Dr. Meisel, you used in that example your daughter. Are you suggesting that we're testing our sons at age 25 as well?
I think if you have a genetic mutation, it's very important to test your sons as well. And I think, the extent, again, as we talked about, just, in general, knowledge being powerful. And a lot of these genes now we know conferring risk, not just for breast cancer, but also for things like prostate cancer and colorectal cancer. I don't think it's unreasonable to test as well for sons. And certainly if you're a son of a BRCA mutation carrier, you would want to know about that. So yes, I think it goes for all children.
And what if you're not a BRCA mutation, but what if you're a survivor?
A survivor of breast cancer?
Mm-hmm.
I think if you're a survivor of breast cancer and you're wondering about your family history, it may be prudent to get testing done yourself first, especially if you're the adult in the family, before thinking about testing a younger family member who doesn't have cancer. But I think once that person, young adult, comes of age and may want to think about genetic testing, some of those same things would apply. When we talked about testing and sort of, should I get tested or should I not get tested? For a young man, what is that young man's family history? How hungry for that knowledge is he? Does he feel connected to a healthcare team that could guide him through should he test positive for a mutation? And is he in a place in life where he wants that information? And I think if all those signs point to, yes, I'm ready and I want this done, then going through JScreen or another organization or a genetic counselor is perfectly appropriate.
Maybe this is part of the question also, but if a woman has had breast cancer, say years ago and had genetic testing years ago, I mean, you were asking about updating testing, and I don't know, Dr. Meisel, in your clinic, like, does this come up, and what would you recommend?
Yeah, it does come up, not every day, but it does come up with some frequency, especially for patients who, I've had people in my clinic, for example, who tested negative 10 years ago when they had a first breast cancer, but then, come back to my clinic, now I haven't been here for 10 years, I've been here for 9, but may come back to me with another breast cancer. And then within that interim period of time, other family members that have been diagnosed and maybe a family member who's since tested positive. Those patients sometimes ask, should I get tested again? I was negative back in 2011. And I say, yes, absolutely. And I have had people come back positive a second time. So I do think, that question, as it continues to come up, whether it's because of new diagnoses in the family or just a curiosity about updated testing, is totally appropriate to do.
See, and there's a question here about, did genes change throughout your life? So when we talk about these kind of changes that are passed from parent to child, no, you're born with those changes. So these are called germline mutations. It's something that you're born with, that you inherited from one of your parents. But generally, I mean, cancer overall is genetic, meaning that it's related to genetic changes that happen in cells. And so there's also what we call somatic mutations, where during your life something happens to a gene for whatever reason, and it causes cells to start dividing abnormally. But these types of changes are passed down from parent to child, and what you get is what you get from your parents.
Yes. No, that's a really good way of explaining it. And I think there's a lot of talk these days too about genomic testing. And if you're in the cancer world, next generation sequencing. And a lot of that, what that has to do with is actually looking at the genes in the cancer itself, which can be dynamic and can change over time. And we're learning a lot more now about, how those genes in the tumor itself can change and mutate, and how that might allow us to really personalize cancer treatment for patients over the course of their journey with the disease. But as far as inherited mutations and mutations you would test for when you do genetic testing, those are mutations that you're born with and you keep throughout your life.
So let me just clarify. So you're saying if you're tested for BRCA1 and BRCA2 10 years ago, then that can't change because that's what it is. But you're saying there could be other genes that now you're testing for, so that is why you should get retested? Is that what you're saying?
Actually both, because there are other genes that we now know about, but also even within the BRCA1 and 2 genes, our ability to see other changes in the gene has improved over time. They used to do testing and just look for some common changes in the BRCA genes. Now they're sequencing the entire gene. They're looking at it top to bottom. You can actually see thousands of different changes in the gene now. So yes, the testing is improved even for those genes.
It's not that your own genes have changed. Your genes are the same from birth onward, but the testing and our ability to detect those changes has gotten better over time.
Thank you.
Yeah. And I think there's another question in the chat about prostate cancer, and is that an inherited disease? And I would say it can be, probably less likely, although we're learning more and more about different genes like CHEK2 that may also contribute to prostate cancer risk. But prostate cancer is one of those diseases that is more prevalent in males with BRCA1 and BRCA2 mutations, particularly BRCA2. So it is one of those things that we think about when we find men with prostate cancer, particularly at an early age. I mean, prostate cancer is one of those cancers that's more and more common as men get older. But if you see men in their 40s, say, or even early 50s with prostate cancer, those are situations where you might be more inclined to look for a genetic cause. Let's see. And then another one came up. Are you still at risk? This is from before. Are you still at risk for breast cancer even after having both breasts removed? So that's a tricky one. And people ask me that question a lot. I think the answer is you can never say that your risk is totally, completely 100% without a doubt gone. But most patients who have a bilateral mastectomy done with a breast cancer trained surgeon are having such a vast, vast majority of actual breast cells removed that the risk of getting breast cancer after that is virtually zero. I would say that if you've had breast cancer already and you're having mastectomies after a diagnosis of cancer, the chance of that cancer coming back is not necessarily zero, because those cancer cells could be still sort of milling around from before you had your surgery. But the idea that you, especially for risk reducing mastectomy, that you would be at much, much reduced risk is true. And then the tricky part too is that after you've had a mastectomy, you can't really screen that breast reliably. So the good news is that you buy out of any screening, such as mammograms or MRIs or things like that. But I think that can be initially sometimes something that causes a little bit of fear or uncertainty in patients who've had mastectomies, where they realize, oh, wait, like I'm not having screening anymore. And we explain that it's really because you've just surgically removed the organ that we would otherwise screen. But I think that can be something that's a little bit disconcerting at times. So important to think through and talk through as you're thinking about surgical options.
And then I think we had a couple of other early questions. We had a question about insurance, whether genetic test results could impact your ability to get insurance and what type of insurance. And we get that question a lot through our program. So some legislation was passed, the Genetic Information Non-Discrimination Act, back in 2008 and 9, which basically protects a person from being discriminated against in their employment and also around health insurance if they have a genetic change, including in a cancer susceptibility gene. So life insurance and disability and other types of insurance don't fall under that legislation. And generally what we tell people is, if you're interested in having this type of testing done, it would be a good idea to, and you don't have a history of cancer, because if you have a history of cancer, that's already in your record anyway. But if you don't have a history and you're just interested in finding out about your hereditary cancer risk, it's a good idea to already have those types of insurance plans in place before you do genetic testing. So the vast majority of the time, nobody's even going to ask you about it when you apply for a policy, but it's just a good idea to go ahead and have that in place. Once you have a plan in place, they can't come back to you and take it away or raise your rates. But it's a good idea to think about that before you test.
Yeah, absolutely. Always good to be prepared. Another question that kind of stems from that is this question about family members being nervous about genetic testing. So how do you explain to your family members some of the benefits of knowing your genetic risk? So I think, a lot of that is sort of encompassed in some of the things that we've talked about tonight. I think it can be different for patients who are, the family members are thinking about getting tested because they know someone in their family has a mutation versus family members who don't necessarily think they might be at increased risk, but where you're encouraging them to get testing for some reason. I think more commonly this comes up for me when patients in my clinic have been diagnosed with a BRCA-associated cancer and are found to have the mutation. And then they tell their children or their siblings, and invariably some children or siblings will run to get testing right away. Others will hesitate a little more. And sometimes my patients ask me, how should I talk to them about this? Like, I'm really nervous that my sister hasn't gotten the testing yet, and I want her to, to learn and to find out. And I tell them kind of a bit of what we've told you guys tonight, that knowledge is power. And understanding your mutation status can help you really understand your risk. If you don't have the mutation, then it can be kind of a weight off. Then you didn't inherit that from the part of your family that has it. And you can pursue regular, screening for those who potentially don't have any increased risk of cancer. But on the other hand, if you find you have a mutation, then you can actually act on that and choose to have preventative surgery or choose to do enhanced screening where you might catch a cancer if it does develop earlier, as opposed to just kind of, sticking your head in the sand and hoping for the best. So I think a big piece of that is encouraging people that getting testing done will open up options for them, making them feel safe with those options and making sure that they're connected within the healthcare system to doctors who can assist them in making important decisions around this. See if there are any other questions. One about PARP inhibitors, those pills I was talking about before. What are the side effects, and are there other patients besides BRCA mutation carriers who qualify for that kind of treatment? So it's interesting. So for me, someone who treats cancer pretty much all day, every day, I think a lot about these advances. And for BRCA mutation carriers, PARP inhibitors have made a huge difference, both in the treatment of breast cancer and in ovarian cancer. And one of the things that's great about them is that they are a pill, so people don't have to come in for IV treatments. And the side effects are, for the most part, pretty mild. Some of them cause a little bit of nausea, which we usually alleviate by giving an anti-nausea medicine at the same time as the pill itself. And some of them can cause some decreases in the blood counts, which we account for by monitoring blood counts approximately monthly when people start the pills, and then every 3 months once they're settled on a dose that works for their blood counts. But other than that, most people actually do pretty well with them. And so it is a very nice way to be able to give people something to reduce their risk of their cancer coming back, or reduce the risk of their cancer progressing without impacting their quality of life as significantly as some of our other medications, unfortunately, sometimes do. So right now, the approval for those pills is just for, in breast cancer, just for BRCA mutation carriers. But there is a growing body of data that the pills might also be helpful for people who carry certain other mutations. So there was a study done in patients who carried other mutations that were similar to BRCA1 and BRCA2 in terms of how they act, but not exactly the same. And that the early study found that PALB2 mutations, for example, patients who carry those mutations and have breast cancer often respond much the same way. So now there are expanded studies looking at that gene and at others to see if patients who carry those genes might respond to PARP inhibitors and therefore be candidates for those also. And I do think that we're going to see movement in a positive direction in the coming years. So lots to be hopeful for on the cancer spectrum for sure.
Great. Are there any other questions?
Don't be shy. And if you think of questions after the fact too, we're always happy to take those questions through Jennifer or others and answer them personally.
Well, I'd like to thank Dr. Meisel and Karen so much for this incredibly informative session tonight. I know I've learned a lot, and I hope everyone here has learned a lot. If you have questions, info@AtlantaCure, or if you know me, email me personally, and we'll get them to Dr. Meisel and Karen. And like I said, we recorded this, so we will share the video. And again, check us out online and check out our Instagram. And thank you all. Good night.
Thank you.
Thanks so much.